Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. On this program, we explore stories from the field about how real organizations are dealing with this change. As always, you can follow the show on Twitter at #VoicesInVBC and follow SPH on Twitter at SPH Analytics. On the program today, I'm excited to be speaking with Dr. Hassan Rifaat, CEO, who also goes by Haas, and Dr. Averel Snyder, CMO and co-founder from Vatica Health. Welcome to the show. It's great to have you both.
Thanks, Matt.
We are very interested in hearing about your work in the risk adjustment space. But before we do that, why don't we hear a little bit about both of you? Haas, you want to go first?
Sure. I'm a biochemist and a physician by education. After medical school, I went into venture capital briefly and then made my way into managed care health plan operations in the early 90s, and I've been in the health plan space ever since. I started out in a role building alternative medicine networks for Oxford Health Plans. Then I moved on to roles at Humana, and then Coventry, and then more recently Windsor Health Plan, which was owned by Munich Re. And through that journey, I learned a lot about what it takes to make sure that the health plans do their part for high quality, cost-effective care and trying to achieve the best outcomes and satisfaction for its members. So I'm excited to be here to talk about risk adjustment today.
Excellent, Haas. Thank you. And Dr. Snyder, how about you?
Surely, I was in a busy cardiac surgery practice for about 25 years, so I could easily empathize with providers today. And really looking back retrospectively, I was probably suffering from some burnout when my brother called me about something called the annual wellness visit. And just about the same time, I went to a medical meeting and heard a proprietor of a home assessment company state that PCPs were not capable of doing risk adjustment coding, and the benefits of that coding should go to outside vendors. And I was infuriated and saw a path to try to empower PCPs to do risk adjustment coding. And I joke that I was looking for a challenge more difficult than cardiac surgery, which can only be risk adjustment.
That is a great tee up. Thank you, Dr. Snyder. So to set the table, can you give me and our listeners a quick overview of what risk adjustment is, Haas?
Sure. So risk adjustment is something that was introduced for government-sponsored insured products in various forms back in the 90s and the early 2000s. And it's an important mechanism to make sure that premium is aligned with risk. And so the different lines of business, whether it's Medicare Advantage, commercial ACA exchange products, or some of the Medicaid programs sponsored at the state level, they all need a mechanism to make sure that as they're putting out premium to these health plans to take the risk of insuring these members that sign up for these products, that premium is properly risk adjusted, meaning that those members who are sicker, meaning that they have more conditions to treat, there needs to be more premium flowing to the health plan that insures that kind of member versus a member who's very healthy who doesn't need as much premium paid by the government for their risk. And so risk adjustment is a process where each year the government is collecting information primarily about diagnosis codes that they then use in different models to adjust the premium payments to the health plans that are insuring the risk for those members. And that's the basic process that's just repeated each year. And it's different for Medicare Advantage versus commercial versus Medicaid. They use different models. HCC models versus grouper models, but at the end, the intent is the same. It's to make sure that the premium matches the risk for the members that are covered by that health plan. And similarly, if that risk gets passed down to a health system in more and more of these value-based care at-risk arrangements, that the appropriate portion of premium has been risk adjustment and flowing down to that at-risk health system.
Excellent, thank you. And you touched on one thing there, which is there's not one model that handles everybody, right? Which adds to the confusion. I think a lot of people hear HCC a lot, right? For those of us heavily involved with CMS. But there's many models out there.
That's right. There's a model for Medicare Advantage. There's a model for commercial risk. There's a different model for the MSSP, for the ACOs. There's variation state to state, that monetize both the risk adjustment as well as the quality of care more heavily. So there's a mix of risk and quality. It varies by line of business and whether it's federal or state. So you really have to make sure that for the lines of business that you're in, that you understand what it takes to optimize risk adjustment, to align premium with risk, and to make sure you're compliant with any of the audits associated with that work.
Excellent. Thank you for that. I think that was a great opener. And then, when we were preparing for the podcast, we were talking about your experience with value-based care models over your career that led you to discover the need for a real focus on risk adjustment. Tell us kind of about those experiences and that realization of risk adjustment is such a key component of success in value-based care.
Sure. So, as a early health plan executive, as I started to take responsibility for my first health plans, like most executives, I focused on bending the curve on medical expense trend. That's where so much effort is focused, right? On making sure you're identifying high-risk patients, you're putting them into care management programs, you're doing disease management. In some cases, you're doing utilization management. And there was this heavy focus, on bending the trend and reducing medical expense. But the focus around risk adjustment was really lagging badly. I think a lot of people didn't understand it. They would outsource it to a vendor. And what I came to understand over time was that we were using the same old methods every year for risk adjustment and quality of care, but primarily risk adjustment with retrospective chart retrieval and coding and then home assessments. And what I came to understand is that health plans really weren't trying to engage the physicians to do this work, on a large scale, including me. I attempted to do this with paper forms I would pass out. But at the end of the day, what I concluded was that we were having mediocre risk adjustment results because we were going around the physicians, particularly the primary care physicians, and not engaging them and figuring out what it took to get this work done. And that's, became extremely clear to me as I was wrapping up my final, health plan assignment, at Windsor. I really optimized risk adjustment with home assessments, retrospective chart review. I took all that coding and I put it into predictive models to identify patients that I could do, good care management and disease management on. But I ultimately never succeeded at finding a solution that I could put out there on a large scale for physicians to do this coding at the place of care. These are the people treating these members. They're in the best position to tell us what conditions they have that are being treated or managed. And so, when I finished at Windsor, I really went looking very intentionally for solutions that could engage providers and that could be done on a large scale. And that's how I found Vatica, and I started my journey into, a PCP-centric model for risk adjustment and quality. And, I'm sure you'll learn more about that as kind of we unfold this discussion today.
Yeah, absolutely. And that leads us, Dr. Snyder, I'd like to ask you, because when we were talking earlier again, mentioned that the care provided is often better than the care documented. Tell us a little bit more about that.
Surely. Clearly today, the increased administrative burden in the current environment is enormous, whether it be quality measures for MIPS, STAR measures, or any of the CMS initiatives, there's a huge time constraint put on the provider, both to care for the patient and provide this intricate documentation. You know, physicians or providers will always put care first, and documentation will always come second. You know, when I was a practicing physician, I knew my patient got a breast mammography. I knew they got a colonoscopy. The documentation was not as important to me as actually providing the care. And as we know today, we recognize this problem, and now we understand the value to the physician to provide some clinical help to the practice for this documentation purpose.
Right, yeah, and that's, you know, what we always hear about with the burnout. And, you know, you see the stats where so many clinicians end up going home after a long day and have 2 hours of documentation that they need to complete, right? And the such negative ramifications of that on our future, right? And future clinicians and care providers saying, that's not really how I want to spend, you know, over 50% of my life and career is documenting. So it's just become a bigger and bigger issue as time's gone on.
And I always get upset when I hear people say, well, this program will increase quality of care, or this program will help your quality of care. You know, overall, I think providers or physicians provide quality care now. What they really need is help reporting that quality.
Right. You know, so as we've gotten into this and we've talked about some of the challenges and Haas, really that focus on PCPs, what are the obstacles that the average PCP or primary care provider to transforming his or her practice, you know, from a risk adjustment perspective? What do PCPs have to do to be successful in the new, I'll say new world, but it's been around for a while, right? We just seem to be transitioning through it for a long time, the new value-based care world.
Yes, I'm going to actually let Abe answer that question. Go ahead, Dr. Snyder.
Great, because I think this is a critical question. And sometimes I think as far as obstacles, there are 3 obstacles that you don't hear people talk about a whole lot. And we know, I mean, we've talked to thousands of PCPs, and the first is really that they're uneducated with respect to risk adjustment and how their patients and their practices are affected. They don't understand that the lack of resources will eventually affect the care of their patients and even their patient premiums to some extent.
Right.
And there is an underlying problem that I never hear talked about, and that's the traditional adversarial relationship between the providers and the plans. And that doesn't encourage the providers to do the risk adjustment. I mean, the providers are saying to themselves, why should I help the plan with this risk adjustment? I don't see the value to me, my patients, or my practice. And this adversarial relationship with inadequate incentives does not bide for a formula for risk adjustment success, and that needs to be changed. As far as what PCPs have to do to be successful at value-based care, well, there's no question that success in value-based care is dependent on additional resources. And those resources are necessary for things such as coordinated care, medication management, evidence-based treatment protocols, post-acute care utilization, and need to access systems really with real-time information so that systems or providers could avoid duplicative services, hospital readmissions, and that's just, you know, to name a few. And those resources all depend on appropriate risk-adjusted documentation and coding. So as Haas said, that reimbursement is aligned with the severity of the disease in a practice or health organization population.
Risk adjustment and the many different ways of doing it to many of us, and I think many in the industry, including the people doing it, as you stated earlier, seems to be a black box. How does a provider become comfortable with the concepts of risk adjustment?
Well, I know that certainly one of our goals is to educate the providers on how risk adjustment affects their patients and their practice. I mean, that's the only way to engage a provider, is to know how it affects them personally. They don't understand right now how appropriate documentation and coding affects resources. That's critical. If the resources are affected, it's just not possible to be successful when it comes to value-based care. And those resources are necessary to manage patients with chronic disease, or in the end, it's the patients that really suffer. And we've also recognized, by the way, that a very good way to get providers on board is for the payers to generously incentivize providers for risk adjustment work.
How, this will be a tough one, but maybe percentage-wise or just uptick that you've seen, how many payers are taking that approach? Do you see more payers getting aggressive with their incentives, or no, it's not really happening yet? Curious what you're seeing in the market.
It's not happening Without a little push from the outside, like we push. And we don't like to engage a organization that's not willing to incentivize our providers. We are a provider-based organization for providers, and that's how it should be for every plan. Every plan should have the provider as well, the patient as their first order of business and the provider second. So they should be doing those incentives, but they're not without encouragement.
Not surprising, unfortunate, right? But not surprising.
Absolutely.
We talked about approaches that aren't working and some of the barriers that are perceived to be barriers that are actually myths out there, right? Things that are potentially holding people back that really shouldn't be. Could you tell us a little bit more about that, Dr. Snyder?
Well, a lot of it is repetitive. The perceived barriers that are actually myths. Well, in the industry, the perceived barrier is that the providers are not capable of doing risk adjustment, documentation, and coding. And I think that's false and a myth. They are best prepared to do risk adjustment and coding and documentation. They see the patients face-to-face in the office. They have access to all the patient information. They are the primary caregivers. Who better but the providers to do risk adjustment and coding and documentation? I think once providers can get over that adversarial relationship, receive appropriate incentives, and understand the value to both their practice and patients of risk adjustment, coding, and appropriate documentation, providers will be very successful at value-based care.
We've talked a lot about the challenges. Haas, I'd like to hear about how Vatica approaches the challenges, right? And your unique model for helping providers be successful. And let's dive into that and hear more about that.
Sure. So, I joined the company in February 2014, about 2.5 years after Dr. Snyder and the other co-founder, Steve Zuckerman, started the company. And it's really been an evolution to get to the right answer. So, as we started to sign up our first health plan sponsors, we primarily focused on our technology that we brought out to the place of care, taught the PCPs how to use it. What we discovered was that there was still way too much clinical and administrative work to be successful at doing this on a large scale on most of the patients. And so we quickly came to the conclusion that we had to add nurses and then administrative support to help the providers. There wasn't a lot of EMR integration there. It's still limited today. And so we said, well, we're just going to have people do the work. And we would have our nurses pull down all the information for a particular patient from the health plan that we had received. They'd go into the EMR and spend between 45 minutes and an hour mining both digital as well as images for data that was critical to our process and preparing that work for the PCP. And so the PCP could simply spend 5, 10, or even for a really sick patient, no more than 15 minutes after the encounter to do the appropriate coding and documentation in a way that was simple for them to understand and very effective in terms of being complete and compliant. We also learned that we can't make the decision for the physician, and so we have to make sure that we give them reasonable choices that have been properly structured with guardrails based on the information that we've gathered. And then on the back end, Dr. Snyder has a team of clinical coders that are reviewing every one of those cases to make sure that the coding and documentation is satisfactory. If it's not, then we will delete that code in terms of the file that we send to the health plan. We don't the medical record that's created, but we simply say there's not enough documentation or the coding was incorrect. Some health plans give us the opportunity to actually send a query back to the physician to try and correct the coding or documentation. But we learned, toward the end of 2016, early 2017, that we needed to do QI review, on, all these doctors and all these codes. The next thing we learned, as Dave mentioned, is that, there wasn't really a even basic understanding of coding and risk adjustment by the physicians. And so we implemented a process with all the data we had from QI review about those physicians that needed help. And we created videos and Vatica University, and we even have, CME courses now that we push out to the providers when they're initially getting trained. And then also if we feel like they need it based on what we see in the QI results. Our goal is not to try and drive the highest HCC value for our health plans. The goal is complete and compliant coding that represents the most accurate risk associated with that member, so that the health plan can submit that with confidence to the government to receive the appropriate premium and to make sure the best care is offered in the products that are available in that market. So, and then for the health systems, once again, for their membership block, that it's properly risk adjusted, well documented, and that those associated premiums or percentage of those premiums are flowing down to them as an at-risk organization. So we're really excited that we've figured out how to have a PCP-centric model that's well supported with data, technology, and then clinical and administrative support at the place of care that enables these providers to do this successfully. And I think that's what's really led to our success and growth, and generally the success and growth of this whole space. I think the whole PCP-centric model, the in-office model, and by extension some of the things that are now happening within that office with telehealth, and the kind of work that we and other people do to support providers in that model is really the new model. Meaning, I think that retrospective chart review and home assessments, I think that's the last generation of risk adjustment.
Right.
I think we're now entering a phase where we're in the next generation and it's focused on a PCP-centric model. And I think health plans are understanding that PCPs can do this, and they don't have to make a trade-off to say, to get higher compliance, I need lower yield. No, you can have complete and compliant coding that is appropriate for the risk adjustment to provide adequate benefits and exceptional benefits for those members, great reimbursement for providers, and everybody wins. It's an efficient and properly risk-adjusted system, and everyone understands that the key now is in office with a PCP-centric focus.
And one of the things, you said it right there at the end, but I had as you were talking, is it's a win-win model, right? The providers win and the plan or the health plan win as well, because they're getting what they need. And as you stated when we first started, when an audit comes around, I'd assume your confidence level is through the roof that you're not going to have any issues.
That's right. I mean, there's so many, everybody wins. Even the member wins. When things are properly risk adjusted, health plans can offer zero premium products with low copays. They can provide reimbursement that is good reimbursement, not poor reimbursement for the physicians and facilities that care for those members. And they, as a health plan, can make, a reasonable margin for the work that they do in this process. And the government can see that they ultimately are paying for the efficient and effective care that they want, right? The three-part aim, right? Better health care, lower cost, right? So at the end of the day, everybody is winning, but it takes effort, right? This is not just, flip a switch and, we go to, a new model that's, happy and better. It takes work. We have, people on the ground side by side with these physicians and their staff to make sure that they're successful and figuring out how to get into the workflow in a seamless way that doesn't interrupt the care that they're already doing.
Right. That seamless interjection in the workflow is so critical, right? Regardless of what anybody's doing, you can't screw up the workflow. And then I'm going to get myself some brownie points with Dr. Snyder by calling out now the quadruple aim, right, of the provider side of things there. So, Haas, you're in trouble, and I win this round.
Okay.
Yeah, you're a good man.
Well, guys, as what always happens on this is we're out of time before I'd like to be out of time because I think we could have a lot more discussion, but I really, really enjoyed this. This is the first time we've really talked about risk adjustment. Which is really great to dig into for all the reasons we talked about. So thank you, Haas and Dr. Snyder. I appreciate you guys for joining us today and taking the time.
My pleasure.
Thank you, Matt.
Thanks to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInZBC. And be sure to follow SPH on Twitter at SPH Analytics. And of course, you can follow me and we can connect on LinkedIn. I'm Matt Fusan, bringing you the voices in value-based care you should hear. Until next time, have a great week.